everyone, and thank you for joining us today. I would like to welcome you to Infarct Size, Microvascular Obstruction, and Outcomes in STEMI, an expert panel discussion. My name is Nadia Sutton, and I am an assistant professor and physician scientist clinically focused on interventional cardiology at the University of Michigan. It is my sincere pleasure to be joined today by Dr. Suzanne de Waha, who is the head of clinical research in the Department of Cardiac Surgery at the Heart Center Leipzig in Leipzig, Germany. I'm also joined by Dr. Jay Travers, senior consulting cardiologist and interventional cardiologist at Minneapolis Heart Institute in Minnesota in the United States, and Dr. Babar Basir, an interventional cardiologist and director of acute mechanical circulatory support at Henry Ford Hospital in Detroit, Michigan, United States, and Dr. Dan Burkhoff, director of heart failure, hemodynamics, and mechanical circulatory support research at the Cardiovascular Research Foundation, New York, United States. So before we start, I would like to mention that today's agenda includes an overview of microvascular obstruction and infarct size and ST elevation myocardial infarction by Dr. Suzanne de Waha, followed by a discussion by all faculty. Some of the questions we would like to consider are: which patients are at the greatest risk of microvascular obstruction and large infarct sizes? How can microvascular obstruction be diagnosed and treated? And what is the role of the interventional cardiologist in mitigating the impact of STEMI on patients' infarct sizes? And this will be followed by some time for audience question and answers. So the learning objectives today are to develop an understanding of the impact of infarct size and microvascular obstruction on clinical outcomes of patients who experience STEMI, and the science behind possible new therapies for reducing infarct size. This program was supported by ZOLL TherOx. And without further ado, we welcome Dr. Suzanne de Waha, who will present overview of the problem, microvascular obstruction and infarct size in STEMI.
Hi, ladies and gentlemen. My name is Suzanne de Waha from Munich, Germany. I'm an interventional cardiologist, currently working for the Department of Cardiac Surgery in Leipzig. There I am the clinical research coordinator. So thank you for the opportunity to give you a short insight into infarct size, microvascular obstruction, and outcomes in ST elevation MI. Acute myocardial infarction is a major contributor for mortality and morbidity, as you all know. Each year, more than 800,000 people in the United States suffer from an acute myocardial infarction. This translates to an American suffering from an MI every 40 seconds. It is well recognized that after approximately 40 minutes of coronary occlusion, myocyte necrosis starts to occur. It starts at the subepicardium, and with prolonging duration of ischemia, increases towards the subepicardium as a wavefront. Time is muscle, and rapid reperfusion, meaning reopening of the artery, thereby supplying the myocardial muscle with oxygen again, is of crucial importance. And if performed in a timely manner, primary PCI, mechanical reperfusion, is superior to the pharmacological approach. In the last decades, we made great progress with respect to prognosis in patients with acute myocardial infarctions. However, in the last years, the event rates are plateauing. So by means of broad implementation of mechanical reperfusion and shortening of symptom duration until reopening of the artery, we could significantly improve prognosis. But right now, we need adjunctive therapies to further improve prognosis. Reperfusion success is of crucial importance for patients' prognosis. And in the clinical setting, reperfusion success is assessed by the angiographic TIMI flow post-PCI in the cath lab. We achieve optimal epicardial reperfusion defined as a TIMI flow of 3 in more than 90% of all patients. However, epicardial reperfusion does not translate into myocardial reperfusion. Even if a patient is mechanically reperfused by primary PCI in a timely manner, the patients face a grim prognosis with heart failure developing in the weeks, months, and years after the acute event. On top of the irreversible myocyte necrosis occurring before reperfusion, the vast majority of patients display microvascular dysfunction. And evidently, if the microvasculature is impaired, there is no reperfusion on the tissue level. So with shortening of door-to-balloon times, shortening of system delay, and achievement of optimal epicardial reperfusion in more than 90% of all patients, we now have to focus on microvascular integrity. Microvascular injury occurs during occlusion by ischemia itself due to in situ thrombosis and loss of vascular integrity. However, even after reperfusion, in the presence of patent epicardial flow, microvascular injury continues to occur. This is due to cellular plugging, embolization, vasospasm, and myocardial edema. All of these factors trigger infarct expansion, microvascular obstruction, and even intramyocardial hemorrhage. These factors significantly affect prognosis due to adverse left ventricular remodeling and subsequent heart failure. So we truly need to assess reperfusion success, including total infarct size and the microvasculature. One option to quantify reperfusion success is imaging. By means of cardiac magnetic resonance imaging, we can quantify and we can visualize and quantify reperfusion success directly. As you can see here from a canine model, the CMR images below correspond to the histopathological images above. So cardiac magnetic resonance imaging can be truly understood as an in vivo histology. These white zones in the images below, in the CMR images, correspond to the infarcted zones. Why do they appear white? In the viable, non-scarred, non-fibrotic, and non-ischemic myocardium, the contrast medium gadolinium is quickly washed out. However, in the non-viable cells, gadolinium persists longer. And if we acquire 10 to 15 minutes after contrast medium administration, these late gadolinium images, then we see this white hyper enhancement. And we can truly assess the extent of infarcted myocardium expressed as percentage of left ventricular mass. Again, using late gadolinium enhancement images, we can assess microvascular obstruction. Here you can see this dark hypo-enhanced zone within the white hyper-enhanced infarcted area. Why is it dark? Because no contrast medium at all enters these zones. So microvascular obstruction, or MVO, is the CMR tomographic equivalent of the no reflow phenomenon, but on a cellular level. Microvascular obstruction is present in more than 60% of all patients, so it's much more frequent than angiographic no reflow. And a post-PCI TIMI flow of 3, meaning optimal epicardial reperfusion, is present in more than 90% of all patients with microvascular obstruction. And the most severe consequences of myocardial ischemia is intramyocardial hemorrhage, which we can also visualize by cardiac magnetic resonance imaging. Here, the microvasculature has lost its integrity completely, and the red blood cells exit into the extracellular space. Are these CMR tomographic parameters prognostically relevant? To finally answer these questions, Greg Stone performed a meta-analysis including more than 2,500 patients initially enrolled in randomized controlled trials. So all of these patients underwent contemporary primary PCI in a timely manner. And as you can see here, we could observe a strong graded relationship of infarct size with all-cause mortality and heart failure hospitalization. Patients with large infarcts had a more than 7-fold increase of risk as compared to those with small infarcts. By multivariable analysis, including a large set of clinical and angiographic parameters, infarct size was identified as a strong independent predictor for clinical outcome. Every 5% increase of infarct size contributes to a 20% risk increase for all-cause mortality or hospitalization for heart failure within 1 year after primary PCI. And similarly to the meta-analysis of infarct size, we performed an additional meta-analysis focusing on microvascular obstruction. And again, we could observe a strong graded relationship for microvascular obstruction and clinical outcome. Patients with large extents of microvascular obstruction had a more than 2-fold increase of risk as compared to those with no microvascular obstruction. And similarly to infarct size, microvascular obstruction was identified as being a strong independent predictor for adverse clinical outcome. And every 1% increase in MVO contributed to an 11% risk increase for all-cause mortality or hospitalization for heart failure within 1 year after primary PCI. So to sum up, we made great progress in the treatment of STEMI patients, mainly by means of broad implementation of rapid mechanical reperfusion. However, a significant amount of myocardium, which is theoretically salvageable, is currently not salvaged by standard treatment. On top of the irreversible ischemic cell death, we have microvascular damage, no reflow phenomenon on a cellular level, as well as reperfusion injury. So we need adjunctive reperfusion strategies on top of epicardial reperfusion by primary PCI to further optimize patients' prognosis. So microvascular function is the relevant battlefield of STEMI therapy in 2022. So back to the patients. In our daily clinical routine, we see those patients. We perfuse them by primary PCI in a timely manner. We achieve optimal epicardial reperfusion, but still they display large infarcts with impaired microvasculature. To improve the prognosis of these patients, we need adjunctive therapies, and one option is SSO2 therapy. SSO2 addresses the zones of residual microvascular ischemia. By increased oxygen delivery, inflammation, edema, and local coagulation is reduced. All of this leads to reduced infarct size, improved microvascular function, thereby positively influencing left ventricular remodeling after the acute event, which translates into improved prognosis. So I guess we all agree that there's work to do, and we need to continue to work hard to further improve patients' prognosis. Thank you for your attention, and I'm happy to discuss with you and open for your questions.
All right. Thank you so very much for that excellent presentation, Dr. Dawaha. That was really informative, and I think it definitely brought up a lot of important points that we can discuss in a lot of more detail. So we have some time to have some discussion, and there is an audience chat function so that you can submit questions. And so we'll talk through some of these considerations, and then we'll go to some of the audience questions. We already have a couple, but please feel free to enter some additional. So Suzanne, I'll direct my first question to you. Tell me a little bit about, when we see patients in the cath lab and they've had a STEMI, is there any way for us to be able to tell, which patients have or are at risk for developing microvascular obstruction? I know that you kind of touched on this as, with regard to the TIMI flow, and the angiogram is maybe not always predicting it. But yeah, I mean, who's at risk?
Well, that's a very good question. First of all, there is no possibility to directly visualize and quantify microvascular function in the cath lab within clinical routine. We see TIMI flow post-PCI3, so optimal reperfusion success in more than 90% of all patients, but still more than 2/3 of these patients display microvascular obstruction. So TIMI flow alone is not enough. We have factors indicating large infarcts and microvascular obstruction. That's, for example, anterior infarction, proximal occlusion, TIMI flow pre and post PCI, collateral supply during occlusion or thrombus burden. Also, we have ischemic duration that significantly influences the development of microvascular obstruction. And of course, also individual patient characteristics, such as the presence of diabetes mellitus. However, there is unfortunately not an exact measurement, score, or predictor for microvascular obstruction. All patients are at risk for development of microvascular obstruction. And we could also demonstrate this in the meta-analysis, demonstrating that the presence of microvascular obstruction is an independent predictor for adverse outcome, independent of angiographic and clinical characteristics.
That was very helpful. So no, thank you so much for clarifying some of those points. Babar, I guess my next question I'll ask you. So what do you think? I mean, should we be trying to get at if the patient has microvascular obstruction in the cath lab? I mean, is this something, or should we be trying to measure this routinely in our patients post primary PCI? Do you think that this is something we should be kind of integrating into our clinical practice, knowing that it influences outcomes?
I think so. I think Suzanne actually presented really compelling data on infarct size and increased levels of MACE, worsening microvascular obstruction and increased level of MACE. And, we have to ask ourselves, the question is, what would we want for ourselves? What would we want for our patients in the long run? And one part of it is to get out of the procedure. And I think as interventionalists, we focus in a lot on that. We want to have a safe outcome, a good outcome in the procedure. But we really have to focus our attention on the long-term effects of this myocardial infarction on these patients. We leave these patients potentially with a long life ahead of them. And a lot of that life may involve heart failure. And despite the advances in medical therapy with heart failure, having to live a life with chronic heart failure is challenging, and we know that very well. And so I think that having the opportunity to study this more, it's been well demonstrated in a randomized control trial in the AMI-HOT2 trial that use of supersaturated oxygen is associated with reduced infarct size. I think that is a really compelling argument to use it routinely in anterior AMIs.
Yeah, no, I agree. I think that I think we have still a ways to go in the field of STEMI management to improve outcomes for our patients, which seem to have kind of plateaued. Dan, maybe tell us a little bit more about, different ways you think that we could potentially try to mitigate patient risk and what the mechanisms of some of those interventions might be.
Yeah, sure. Thanks. In Suzanne's presentation, she really outlined nicely the mechanisms of MVO, microvascular obstruction, and they're multifactorial. But I think it's very important to recognize that every patient with ischemia is at risk for developing microvascular obstruction. It's not at this point, we don't have predictors in individual patients, but as she also pointed out, there's evidence when measured of more than 60 to 70% of patients have evidence of microvascular obstruction. We don't have tools that are easily applied in the cath lab to make these measurements in real time. It's something that we can measure retrospectively using CMR, but we can't measure this in the cath lab easily at this point. We can measure it accurately in the animal lab, and there we draw that's where we draw our inspiration, shall we say, for what we do here in the clinic. Is we know that there are specific therapies that can address this, and right now, really the only one that's been proven in clinical trials is SSO2. There have been several many efforts over the decades to reduce microvascular obstruction, but the only one that has really made it into clinical practice is SSO2. And the only one that's approved at this point is SSO2. And I think that this is what we really have to keep in mind. We need to, the mechanisms of obstruction really largely relate to the endothelial swelling and blebs that obstruct the microvasculature. They're not necessarily due to debris that is, what we thought many decades ago that this was debris that was being that was pushed forward and clogging the capillaries. Our understanding of this has really evolved significantly, and we understand now that this is really an issue of hypoxia and ischemia of the endothelial cells, swelling of the interstitium of the myocytes that compress the capillaries. These are all related to ischemia due to the lack of oxygen, even after the epicardial vessel epicardial lesions are relieved. SSO2, delivery of oxygen via SSO2 does not require red cells to get through these let's say, really, really tight capillaries that are being compressed, and that the oxygen that is in the that's in the supersaturated blood can get past these microobstructions and start to treat the endothelium and also the myocardium. And it's that which prevents the further swelling and also mitigates the swelling. So these are the things that have translated from decades of basic research of what is MVO, and then really providing a therapy that really addresses that issue. So I think, and also Barbara really, hit it on the nose as well, is, think beyond what you do in the cath lab. Think about what this patient's life is going to be like for, decades to come, because now people are living longer and we want them to live without heart failure.
Mm-hmm. Yeah, no, absolutely. And I mean, it actually really makes sense. I mean, if, the lack of oxygenated blood is what has caused the problem, that, restoring the ability for cells to use oxygen seems like that would make sense, right? That's how you can potentially reduce the infarct size. So, Jay, I have a question for you. I mean, what do you think, how should we be applying this in our clinical practice, all of this information that we've learned from Dr. Dawaha's presentation and this discussion?
Thanks. I'd like just to build on what Dan said. We've been very interested in the edematous response that occurs as a result of reperfusion injury. We found that there's, in our patients in our STEMI database that we have that have MRIs, we note that there's a significant increase in MVO associated with increasing left ventricular mass. And we think the acute increase in LV mass is due to edema, and that this resolves over several months. And in the subset of patients that have T2 imaging of edema, we find that they have much higher degrees of microvascular obstruction. So we're interested in kind of the extrinsic compression as opposed to the intrinsic obstruction factor that leads to microvascular obstruction. So I think it's interesting, you know, in the swine, if you do not reperfuse the artery, you get very little edema, but if you do reperfuse it, you get an abrupt increase in edema. And I think that's you know, ways that we could reduce edema. And the thought is that the SSO2 may be very good at reducing the reperfusion injury and the edema, because the reperfusion injury goes on, you know, it's just not over when the artery's open. It's an ongoing process. And so I think, you know, that's the whole paradigm of, you know, of treating this for an hour afterwards. I think you could really make a big improvement up front in reducing the ongoing reperfusion injury.
Yeah, those are fantastic points. So we actually have quite a few audience questions, which is great. If others have questions, please feel free to enter them into the chat, and we'll see if we can get through the majority of these. So Suzanne, this is I'll direct this question to you first here. So the question is, does the EKG tell us anything about if the patient's developing microvascular obstruction? You know, I think that this kind of gets at probably this question about, you know, does the patient who has residual or ongoing ST elevations after reperfusion, does that patient have any higher risk for developing microvascular obstruction, or is there a correlation there?
Yes, there is a strong correlation between ST resolution and microvascular obstruction, but we also performed additional analysis many years ago where we could demonstrate that the presence of microvascular obstruction is still an independent predictor for adverse clinical outcome, even in patients with complete ST resolution. So it, as all the other parameters, such as TIMI flow and so on, it gives an indication, but we definitely, there is no option to definitely rule out or rule in ST microvascular obstruction. It's only an indirect indicator.
Got it. So it correlates, but not perfectly. So we don't want to necessarily miss patients who, even though they have ST segment elevation resolution, that doesn't necessarily mean that they couldn't be still at risk for developing microvascular obstruction. So that's very helpful.
No.
But were you going to say something else?
Yeah, I mean, if we have no ST resolution at all, then it is very likely that this patient has microvascular obstruction. On the other hand, if we have complete ST resolution, the patient can still display microvascular obstruction.
Great, thank you for the clarification. So we have another audience question. Babar, I'll see if you can maybe comment on this. And the question is about, are you using physiological assessment to determine microvascular disease or microvascular obstruction in STEMI patients? Maybe if you want to try to comment on that, what your clinical practice is right now in light of the information we have or don't have on this topic.
No, it's a really great question. And honestly, you and Suzanne are probably more expert in this than I, so feel free to answer as well. But I personally don't use IMR here. I think IMR in an acute setting hasn't really been well studied, but I think it is really the most important physiological tool that we do have to be able to answer this question. But how, what's normal, what's not normal? I don't think we're there yet. I think we just need a lot more information to be able to get to that. I know that there's a lot of work in the preclinical model to kind of understand these concepts better. But I think in the clinical model, we unfortunately don't have that yet. But what we do know, just as Suzanne just mentioned, is that the vast majority of these patients who present with a large anterior MI do have some component of microvascular obstruction. And so we do feel that generally speaking, these patients would get benefit from supersaturated oxygen. I'm curious to hear your thoughts, though.
Yeah, so I mean, I totally agree. I think we definitely need more data in this area. I mean, there have been some studies looking at using IMR in the setting of infarct in general. The cutoff would be higher. So whereas with like a stable patient, we were looking at the IMR, and just for the audience information, so that's the index of microvascular resistance, which can be measured with a wire that measures the transit time through the coronary as well as the distal pressure. Typically, it would be done with hyperemia, but that's always a question, you know, in the setting of an infarct, whether or not you would want to administer a hyperemic agent. But whereas we would use a cutoff of about 25 or greater as being abnormal in the setting of a stable patient, typically the number would be higher in the setting of a patient who was having an infarct. Usually 40 is sort of thrown out there as a suggested sort of cutoff for what's considered to be abnormal. But I do think that we would need more information in order to be able to apply this clinically, to try to, you know, state that this, you know, could or could not, you know, help us determine which patients would be a benefit. At this point, without having that information, I would not use physiology to determine if a patient either would or would not benefit from some hyperoxygenated therapy in the setting of STEMI. So that's my take on it. This is an interesting question. Jay, maybe you can answer this one. There's a question about if you've used or if you use contrast echo to identify intramyocardial hemorrhage in patients who have had an infarct, and I guess what would be, the downstream application of that, or what would you do with that information?
Well, we have not used contrast echo for hemorrhage. You can certainly use it. I'm not sure how that works. People have used it for identifying microvascular obstruction. We rely on the MRIs that we get on most all of our large anterior STEMI patients, just to assess degree of microvascular obstruction, as well as you can measure intramyocardial hemorrhage, which is just as important as microvascular obstruction, probably, you know, long term, because the breakdown of the heme products, you know, have been shown to stay for years in the myocardium and serve as a source of fibrosis and chronic inflammation. So, and that's the hemorrhage is probably the extension of the microvascular obstruction. So I think, you know, hemorrhage here is just as important as the microvascular obstruction, and it'll be important to see if SSO2 could reduce hemorrhage, and that would be another important use of this therapy.
Yeah, absolutely. I mean, I think of hemorrhage as being a really sort of a catastrophic sort of complication. It's, to me, just a little bit short of having
kind of like extreme MVO is the hemorrhage part.
Yeah, absolutely. We have another question here, Dan. Maybe if you've got something else to say on that topic, and then I'll give you another question too.
No, I was just going to say that with, you know, hemorrhage is I was just going to say with hemorrhage, that's, you know, loss of integrity of the endothelium, and that is part of the whole ischemia of the endothelial and the capillary anatomy. So MVO, SSO2 should in principle reduce intramyocardial hemorrhage as well. Not as well studied as just the ability of SSO2 to improve perfusion, but I think they probably go hand in hand.
Yeah, absolutely. So there's another question here, Dan, about biomarkers. I mean, have you seen any utility of using biomarkers to determine the degree of microvascular obstruction?
I'm trying to think. I have not seen any of those used, and I'm not sure exactly which ones you would use. You know, aside from, you know, troponin and normal markers of myocardial ischemia and infarction. But I have not seen, or I've not heard, but I may not, you know, I may have missed something, but I've not heard about biomarkers being used for MVO.
Yeah, and I guess as I'm thinking about it, I mean, I'm also kind of thinking sometimes we wouldn't be able to obtain those biomarkers until after the fact, in which case then your window for administering SSO2 has already kind of passed. So I guess I at this point, we don't really have that information. I don't know, Suzanne, do you have anything to add to that?
Yeah, what we see in patients with microvascular obstruction that they display higher markers of higher parameters of inflammation. So everything pointing out to large infarct. I mean, evidently in patients with large infarct, we also see markers of inflammation, and these are higher in patients with microvascular obstruction. But as you said, this is nothing that helps us in the acute setting. This is just the consequence that we then observe.
Yeah,
It's really
no, I
interesting
think so
though
too.
that everyone's theme in terms of the questions is the same, right? How can we get this information at the table? How can we figure this out? And you know, there's a lot of people on the webinar, and I think we should really, you know, spend a lot of time thinking about what are the best ways to know this. And until we have that answer, and until we can investigate, you know, different strategies of being able to identify this, having the understanding that this happens in just the vast majority of large STEMIs that we deal with is an important phenomenon. And I think we're still ahead of the game. You know, there's not a lot of people talking about this. And I think it still shows us that we're on the frontier of something that's probably really important and significant, and it's going to change the care of our future patients.
Yeah, no, absolutely. And I think we were just kind of commenting on that, you know, the number of different negative trials that we've had in the past for STEMI management. And finally, we have something that actually has a proven benefit in terms of reducing infarct size for our patients, which is really something to celebrate, in my opinion. So I think, you know, we certainly want to try to improve the care for our patients. And we've been in a little bit of a, you know, in a sort of a stale situation for a bit. Dan, I hope you don't mind. I'm going to ask you another audience question here, since you were talking about mechanism. There's a question about whether or not it would make sense to think about using things like low molecular weight heparin or GP2B3A inhibitors in patients after primary PCI to try to reduce microvascular obstruction. I think this kind of gets at, I think this is answered maybe with some mechanism. So what do you think?
Well, I'll be curious to hear other people's opinions, but I don't think that either of those approaches really address, you know, what we're trying to achieve. This is not about platelet aggregation or thrombosis. Those things are being addressed. Anyway, patients are getting these medications in general. So this is really addressing you know, a completely different mechanism of ischemia and lack of microvascular flow. So I don't know that those kinds of anti-thrombotic, anti-platelet therapies would offer anything in regard to this particular mechanism. But I'd also be interested to hear other people's opinion.
Yeah, no, I mean, I think it's a great question, and I think that I agree with everything you've said. Bobber, did you have something else you wanted to add?
I was going to say there's multiple things that are happening in our STEMI patients, and we know that the vast majority of these patients aren't getting good antiplatelet inhibition at the time of their MI, and they are left with very high thrombus burden. And I think using IV antiplatelet therapy is helpful in reducing our risk of no reflow, which can definitely impact the infarct size in general. But what's important for the audience, and I hope that they've understood Dan's point, which is that there's multiple different mechanisms here. And the ischemic mechanism is present even when there is good TIMI3 flow there. Hence, you know, the ability to use a therapy like SSO2 to improve outcomes. One of the things that's challenging for early users of SSO2 is that they want to use it in cases of no reflow, for example. But if you're not able to establish epicardial flow, it's very challenging to be able to establish microvascular flow. And so it's really critical to be able to help establish epicardial flow. And part of that may be the use of IV antiplatelet agents.
Absolutely. And we have only a couple minutes left, but we actually have an important question here. And Bobber, I'm going to ask if you can just take the first stab at this question, and then you know, hopefully a couple of others can weigh in. So the question is a very good one, which is, how do you administer SSO2?
Oh, it's actually really easy. So it's you know, it's a pump. like a canister that's driven into the cath lab. It's very easy for the team to use. It takes about 5 to 10 minutes to set up. And so in the cases that we've done, we've been using it on label. And so if it's an anterior STEMI, then basically we ask for the cartridge to get in while we're doing our work. Once we've established revascularized standard of care techniques, IVUS and stenting from our standpoint, typically I'm through a radial approach. And so I'll get a 5 French femoral access. And then basically you take out your guide and you use a specialized diagnostic catheter, which is made by Boston Scientific. And it is a 5 French catheter that goes into the coronary. It's a JL catheter, very simple to use. And then the cartridges are hooked up to the machine. The machine actually does everything for itself. It's a very easy system to be able to follow steps one by one. And then the infusion happens, which takes about 60 minutes to complete. And during that time, you can do your notes, finish up other things, get more information, and you can kind of continue to treat the patient during that time.
All right, wonderful. So I think we are in the last couple of minutes that we have for this discussion. Jay, did you have any last comments or anything else you wanted to add that we haven't covered yet?
No, I would just say we've been with this program now for about 5 or 6 months, and we've done 5 or 6 patients, and I've been very impressed. We've gotten MRIs on all our patients after their high risk anterior STEMI, and then we've done some follow-up follow-up imaging, and I've been really impressed with the recovery that we've seen in the left ventricular function, much higher than what we would normally see in just routine PCI. So trying to get my partners enthused as well so that we can do more of these patients to get more data. Because I guess I would say years ago I was a little bit of a skeptic, but I'm slowly, becoming a believer in the therapy because we have so few options for treating ischemia reperfusion injury that I'm hopeful that we're going to get more data and really make an impact on these patients that have high risk anterior STEMIs.
Wonderful. It's always good when you win over the skeptics. That's usually an indicator that things are very effective. So, Suzanne, any other comments?
No, I think it's an important point very quickly that we need to move beyond epicardial reperfusion. And I think that this might be a little difficult for all the interventionalists. We got the patient reperfused TIMI-Flow 3, and this is an optimal reperfusion success. But in fact, there's a long road to go to improve patients' prognosis. And I think that SSO2 is a viable option for these high-risk patients.
Wonderful. Dan, any other comments?
No, it's just been a pleasure to listen to these discussions. It is rare to see a therapy get approved, of this nature. And I think that we should try to embrace when we have a new tool in the toolbox that we know that data show that it works, that we should make efforts to utilize that.
Absolutely. So sadly, in the interest of time, we must conclude. So this does bring us to the end of the Infarct-sized microvascular obstruction and outcomes in STEMI and expert panel discussion. We thank you again to ZOLL TherOx for supporting this broadcast, and we all hope that you found that this to be very informative. I'd like to thank our faculty, Dr. Suzanne DeWaha, Dr. Jay Travers, Dr. Baber Basir, and Dr. Dan Burkhoff. So thank you again for joining us today, and that concludes our presentation.